Hello, welcome everyone. We will get started at 2 o'clock p.m. Eastern Time. Thanks so much for joining us. All righty, everybody, welcome and thank you so much for joining us today for our fourth installment of LBDA's 2024 webinar series. I'm Julia Wood, the Director of Professional and Community Education here at the Lewy Body Dementia Association, and it's my pleasure to be here with you today to moderate this webinar. Today, we're going to be discussing movement changes in Lewy body dementia and introducing you as well to some new education resources here at the Lewy Body Dementia Association, namely the Lewy Learning Center. So the Lewy Learning Center is the go-to place for free on-demand learning for a range of topics on Lewy body dementia. Today's presentation, Unpacking Parkinsonism, will be part of a series of sessions on the Lewy Learning Center on this topic. Dr. Fleisher will present an overview of the movement changes and how they are treated in our session today. And then there will be additional presentations by other professionals uploaded as a course and broken down into smaller sessions to accompany Dr. Fleischer's presentation. So this is going to allow you essentially to unpack this topic that is pretty beefy. There's a lot to know about the movement changes, how to cope with them, how to manage them. And so this will allow you to learn in your time with your schedule at your pace. So now we have a question for each of you about the Lewy Learning Center. And so Rose Heitoff is our our education coordinator here at LBDA, and she's asking if you visited the Lewy Learning Center yet. So you can give us a yes or a no, but I plan to, so we can kind of see who's with us today. You'll notice too, she has popped a link in the chat for how you can access the Lewy Learning Center. It's free. You just set up a free account and you can go in and view any of the educational opportunities that are there in your time. All right, so it looks like we've got only about 19% of you have said yes, you've already joined. We've got about 43% of you saying no, you haven't yet. And then we've got about 40% that no, but now you're planning to. So excellent. We hope to see you all on there. And you guys, a lot of what this is I don't know if any of you remember our vision webinar from last year that was like 2 hours long. And that's a long time to try to watch and absorb content. So we've done some focus groups and surveys here, and what we've heard from you is that you would like to be able to take this education and information in kind of at your own time and in your own pace. And so this is our attempt to try to meet that request. So before we get started, a few words about the Lewy Body Dementia Association. We're a national nonprofit whose mission is to optimize the quality of life for those affected by Lewy body dementia by accelerating awareness, advancing research for early diagnosis and improvements in care, and providing comprehensive education and compassionate support via our Lewy line. A few housekeeping items. You can select the show captions feature from the bottom of the screen at any time during the presentation to launch closed caption services. You are also welcome to submit any questions that you have using the Q&A button at the bottom of your screen. Following the presentation, I will address questions for about 15 minutes. This presentation is being recorded, and an email will be sent to those who registered with the link to view the recording in about 1 week. To watch recordings of any webinars that you have missed, even from last year, you can visit our YouTube channel at any time, LBDA TV. As previously mentioned, this presentation will also be available as part of a course on the Lewy Learning Center. Also, when you leave the webinar today, a brief survey will appear asking for your feedback about today's presentation. Please take a moment to complete the survey to help inform our future content. All right, so now we'd like to learn more about who's joining us in our audience today. So Rose is going to launch a polling question here, asking if you're a person with Lewy body dementia, a care partner, a friend or family member, healthcare provider, researcher, or other. All right. As usual, our care partners usually lead the charge here, but we're happy to have each and every one of you who's with us today. We'll give that a moment. Excellent. Yep. So it looks like the majority here we've got our care partners for someone with Lewy body dementia. Next, we've got people living with Lewy body dementia. And then we have some friends and family members in the audience, as well as healthcare providers and even some other. All right. So thank you so much for sharing that. Excellent. All right. So for some unexpected and unfortunate news, our presenter, Dr. Jori Fleisher, has had multiple family emergencies this week and is not available to join us live. And she was very upset about that. But as you can imagine, trying to cancel an event with almost 600 attendees is very difficult. So having the big heart that she has, Dr. Fleisher recorded this presentation for us at 1 a.m. and has given that to us to make sure that we all could enjoy it today. So she has had to step into that unexpected role as a family caregiver, as many of you may be familiar with as well. So we are going to show the video and watch it all together. And we will be monitoring the Q&A. We'll be taking questions at the end. And as I mentioned, this will be a course on the Lewy Learning Center as well. Please accept our apologies for this. We did not want to cancel the event, but we also want Dr. Fleisher to know that our heart and our support and our thanks go out to her for taking her time to make sure that she provided a presentation, even in the midst of all the things going on in her life. Okay, so with that, I'm going to turn it over to Rose, who is going to share the video with you. And we will see you in about an hour. Thank you all.
Hi everyone, my name is Dr. Jori Fleisher, and I'm so happy to have. Hi everyone, my name is Dr. Jori Fleischer, and I'm so happy to have the opportunity to present to you on Unpacking Parkinsonism, Understanding Movement Changes in Lewy Body Dementia, or LBD. I am a movement disorders neurologist at Rush University Medical Center in Chicago, proud to be the director of our Lewy Body Dementia Association Research Center of Excellence. So let's get started. Our objectives today are the following: define the various presentations of common movement symptoms in LBD, highlight the medication and non-medication approaches to managing changes to movement in LBD, and identify the healthcare providers who should be in your team to help you best manage your changes to movement with LBD. So we've got a lot together, so let's get started. So a lot of times we throw around the term Parkinsonism, right? What does that even mean? And what are the symptoms of Parkinsonism? So before we get to exactly what the symptoms of Parkinsonism mean, you might have gotten to this talk or to LBDA thinking, wait a minute, I thought that I was diagnosed or that my loved one was diagnosed with Parkinson's, but now I'm hearing Lewy body dementia. What is the difference between all of these terms? So hear me out. Here's my silly analogy. I want you to think about this as a chicken and egg problem under an umbrella. Okay, so bear with me. All right, keep that visual in mind. So we're going to talk about what Parkinsonism means, and that's the movement changes, okay? And if movement changes happen first, these classic movement changes we'll discuss, and then at least a year later, the classic dementia symptoms, including fluctuations in thinking, sort of from minute to minute or hour to hour, visual hallucinations, changes with attention, decision making, if that's separated so that the movement stuff happens first, and then sometime down the line, at least a year later, the dementia symptoms happen, well, then we call that Parkinson's disease dementia, or PDD. But if you flip that chicken and egg, and the dementia comes first, and then the Parkinsonism comes later, or the dementia and Parkinsonism happen within a year of each other, well, that we call dementia with Lewy bodies, right? So whichever one comes first, that's the first part of the acronym: Parkinson's disease dementia, dementia with Lewy bodies, okay? Chicken and egg and chicken. However, the chicken and egg are all sitting underneath the umbrella of Lewy body dementia. So whichever one comes first, if you have both the Parkinsonism and the classic form of dementia, we call that Lewy body dementia. Clear as mud? Okay, so what is this Parkinsonism that we're talking about? right? So let me explain to you as a movement disorders neurologist what I am looking at to make a diagnosis of someone having Parkinsonism, and then how we get from there to what's the actual disease, what's the cause of that Parkinsonism. So to say someone has Parkinsonism, they have to first have bradykinesia, which is our fancy word for slow movements that actually get smaller as a person moves. So, for example, ways to think about this in daily life might be that you or your loved one with this diagnosis starts brushing their teeth on one side. They start okay, but as they move to the other side, the movements are getting slower and smaller and tight and cramped. You might imagine handwriting that starts off okay, but gets really tiny and cramped, maybe slants towards the end of a sentence or the end of a paragraph. We can even see this in someone's walking, where they might take big steps initially, but then they get these teeny tiny little shuffly steps and they're almost marching in place without moving anywhere. Similarly, the voice can have bradykinesia, which is hypophonia. So a voice that starts loud to begin with, but as they get to the end of the sentence, they might be mumbling and their lips are moving, but you can barely. It's almost like someone is putting brake pedals slowly around movement, around the vocal cords. So stuff doesn't just stop, but it kind of tapers off as we go. In the clinic, we test this by asking someone to tap big and fast. We might have them do hand movements like this. And what we're looking for is, do they stay big and fast like that? Are they kind of big to start with, but they're a little bit arrhythmic? There might be breaks in the rhythm, or they might get smaller, or are they really tiny, tiny movements that are really hard to see? And the person is just kind of, they're trying their best, but they're not really moving very big. We ask people to flip flop their hands back and forth. We're looking at facial expression. We can actually see that bradykinesia, that slowness of movement, and how frequently people blink. We're listening to people's voices. And we're also watching how they stomp their feet. Do those stomps stay big and fast and even, or are they kind of tap, 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 tap? And we watch how people move as they're getting up and walking. So that's bradykinesia. If you don't have bradykinesia, you can't have Parkinsonism. Okay, that's the hallmark. So if you have bradykinesia and then at least one of these other things, then we say you have Parkinsonism. So what are those other things? Rigidity, which is a stiffness of the muscles that's involuntary. The person is fully relaxed, and yet, when a neurologist is moving around their limbs, around the different joints, they can feel an extra bit of tightness there. Sometimes we describe what's called cogwheel rigidity, which is nothing fancier than moving around that limb and feeling the little bit of tremor, if there is one, kind of chuck, 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 around that joint. So speaking of tremor, people often think about tremor, but tremor is not there in everyone. And when we talk about tremor, we mean a rhythmic movement around a joint. So it could be something like this, which is sort of pill rolling that people will often describe as the thumb is just kind of going. People can have a shake like this. They could have a shake in their foot, in their lips, in their chin. So that tremor can come and go, typically is more present on one side than the other, um, and is usually present at rest. So when the person is not using that limb. So for example, family might notice it more than the person who's actually shaking. And then finally, changes with balance and posture. So we'll talk about all of these a bit more, but if you have bradykinesia, and at least one of rigidity, tremor, or those balance and posture changes, then you're in this box of Parkinsonism, okay? And the most common thing in the box is Parkinson's disease. However, not everyone who has Parkinsonism has Parkinson's disease. And so we'll talk through some of why that is. But let's take a closer look at some of these symptoms. So here's a video of an actual person with Parkinsonism. They've given consent to be part of this. So this is a gentleman who came to the office with 1 year of right shoulder pain and stiffness in his arm. His wife had noticed that he wasn't really swinging his arm when he walked. And so let's take a look at what we see in this video. So we're asking him to do those taps, and they're okay. They're not great. I would draw your attention that at least when he was tapping on this side, he had a bit of a tremor that snuck out over here when the left hand was at rest. if we see his open and close, it's not so big on the left as it is on the right. You can see a little bit of tremor sneak out there when that hand is actually at rest. And if we look at his facial expression, it almost looks like he's frozen. He's not blinking. Now the video's ended. But when the video was rolling, he wasn't blinking. And that decreased blink, people often pick up on that and say, oh, are they depressed? They just kind of look sad. It's a loss of facial expression, both blinking and just kind of normal emotions moving of the face. So he's a really great example of bradykinesia. We see that bradykinesia in the face. We see the bradykinesia with the taps. It's asymmetric for this gentleman. Let's look at some of the other symptoms. So cogwheel rigidity, that rigidity is really hard to see on a video. It's really something you feel, not that you see. But let's take a look. So here for this gentleman, this is one of my good colleagues who's moving them around. So why do we give people kind of a really cheap massage when they're in the office? We're moving them around and wiggling around different joints to try to get people fully relaxed and then to try to feel that extra tightness. When they're fully relaxed, are we feeling that it's very hard to move around that joint or that it moves pretty easily? So let's watch again. Here, Dr. Paul, often we feel it most around the wrist, kind of move a lot of different directions. It's very hard for people to relax, especially if there's cognitive impairment. It can be very difficult to relax. So if you hear us keep telling you or your loved one to relax, it's not a judgment. We're just trying to get a sense of that symptom. And here's another gentleman, and he has a fairly classic rest tremor. So he's not using that hand, he's not doing anything with that right hand, but it's still kind of tremoring on its own. And it's pretty rhythmic. It's the same joints, same area of the body that's moving over and over. So finally, you might get nervous if you see us doing this in the hall of the clinic, but one of the key things that we test for on the exam is to look at someone's postural stability or their postural reflexes. What does this mean? This really means, do you have the reflex that if someone accidentally bumps into you, for example, you're walking down the street, they brush up against your shoulder. Normally, you might sort of, if they push you this way, you might step back, right? We want to see that people have that reflex to step back, take a good solid step, and catch themselves. You might take a step or two. That's still okay. And so in the office, we test this by pulling people back, and we're trying to pull you hard enough to see if you take that step. So it shouldn't just be a little dinky kind of thing. It's really going to be a big pull. And all of us who do this typically will have the wall behind us so we make sure that you're not going to fall. And so again, here's a colleague sort of explaining what he's going to do, and then boom, checking to see if this gentleman has that postural reflex. So here again, one big step, that's exactly what we want to see. That's normal, right? If there's more trouble with balance or posture, we may see a bunch of different steps, or we may see someone get pulled this way, and instead of stepping back, they just fall backwards, right? And that's a big concern that someone's at a very high risk of falling. Okay, so we talked about those key features. The bradykinesia has to be there, otherwise it's not Parkinsonism. And stiffness or rigidity, tremor, and postural instability. What else makes us think Parkinsonism, or particularly Parkinson's disease, which is different than LBD? Typically, people will have very unilateral onset in idiopathic or regular Parkinson's disease. Someone starting out with DLB may have motor symptoms on both sides. They may be more symmetric. Typically in Parkinson's disease, someone responds really well to levodopa, meaning their stiffness and their slowness particularly respond very well. And they may develop dyskinesias, which are extra involuntary movements, sort of a fidgety, wiggly movement as time goes on. In regular Parkinson's disease, people tend to be responsive to levodopa, meaning they still get a benefit from it for many years. And so the things that are really important about this is people, as I've said before, people often think tremor, Parkinson's, or tremor, Lewy body, but at least 30% of people with Parkinson's disease never have a resting tremor. And people with dementia with Lewy bodies, so egg before the chicken, dementia with Lewy bodies folks may have an even higher percent who never have a tremor. So it's more common not to have a tremor. So as time goes on and people have been treated, and we'll get into treatment in a little bit, some of the other motor symptoms that can develop are what are called motor fluctuations. So what this means is that when someone takes their medication to treat these symptoms, so they're treating the loss of dopamine by giving someone back dopamine or something like it. It's sort of like if you tested like your B12 level and you were low, we give you back B12. Unfortunately, the brain doesn't deal as well with giving back dopamine in a pill form as the rest of your body does with B12 in a vitamin. So it's a little bit more complicated, and your brain is used to seeing dopamine all day long in a steady 24/7 kind of rate. But the pills that we have at this point in time don't last 24 hours. They're sort of there for several hours and then they wear away. And early on in the course of Parkinson's disease in particular, people can take the pill, and even though we say it should only last 4 or 5 hours, they might feel great for 6 or 7. But as time goes on, that window, the length that that pill lasts, we still feel it kick in for a lot of people, but then they feel it wear off before it's time to take the next pill. So that on medication and off medication, we call that wearing off or motor fluctuations. So here's an example of a gentleman who is off of his medication. So what do we see when the meds have worn off? We see the underlying Parkinsonism show back up in its true form. Okay, so let's take a look at him off. Significant. So we can see a lot of tremor. We can see that masked face, that hypomimia, the decreased blinking. His mouth is open more, which we see more as time goes on. That's part of that slowness and muscle rigidity. And let's see if we can see his taps. The video might not be showing up great, but his taps are very tiny. So that's significant bradykinesia. If we watch him walk as his medicines are off, just trying to get up out of the chair is difficult. His posture and his balance are a struggle, so it's hard to push himself up. And here he's actually having freezing of gait, which we'll talk about in a little bit. He's stuck and he can't get moving. So this is the same gentleman, different clothes, same gentleman, with his medicines working. Notice that his posture is a little bit more upright. We don't see that tremor. See if we can skip ahead, see how he's moving. So those taps have gone from this teeny tiny bradykinetic little movements to bigger. They're not perfect. They're not quite normal, but they're bigger. Let's see. We saw how he got up out of the chair before. Let's see if we can capture this moment again. So he's able to stand up on his own now. I don't know if that sounds, and he's able to walk on his own, where he could not when his medications were not working. So the medications are clearly doing something for this gentleman. And this is many, many years in to his Parkinsonism. All right. So I mentioned that as time goes on, people develop these fluctuations. So that's a really key Parkinsonism symptom. And so early on in the disease, the squiggly line, so this is taking a pill, it kicks in, it wears off. And if you look over time, this squiggle stays the same. So each pill, each time someone takes dopamine, it's going to do the same thing in their bloodstream from day one until forever. The challenge is that that person's brain is changing. And as their brain changes, the way that they respond to that medication changes. So if we look, and this is in Parkinson's disease, so the movement coming first, the cognition coming later, the changes thinking coming later. Here, the person, so gray means that they're off, they're slow. The Parkinsonism is really prominent. They take their pills here and they're good. They're good for hours. The whole time, even when the dose is wearing off, they're not feeling it. The tremor's gone. They're doing better. As time goes on, right towards the end of a dose, see here where they dip this little valley, we get back into the gray zone. So maybe 20 minutes before it's time to take the next pill, the tremor comes back, or the slowness or the stiffness comes back, or they're not swinging their arm as they walk. But then the pill kicks in and they're doing really well for most of the time, right? As time goes on, as we get 7 to 10 years into Parkinson's disease, we have more time. It takes longer for that pill to kick in. And at the peak of that dose, a couple of hours in, we may have some extra movement. It's sort of like a Goldilocks situation. We've got not enough porridge, just the right amount of porridge, too much porridge, right? So at the top, we might have some movement, some fidgeting, some shuffling, some dyskinesias. And as time goes on, we find that this white zone where we're sort of just right, that Goldilocks zone narrows and narrows over time. And again, this is for folks who start with Parkinsonism and then develop the dementia later. So Parkinson's disease dementia follows this course. Folks who start with the dementia, DLB, dementia with Lewy bodies, may not follow this course and may not feel those fluctuations in nearly the same way or at all. And then let's talk about another motor symptom, which is freezing of gait. So we saw it when that last gentleman, when he was off his medications, he stood up and he couldn't even get going. So freezing of gait describes a sudden episodic, not there all the time, gait dysfunction. Often it happens when people are off, when their meds aren't working, but as time goes on, it may happen at any given time and be kind of unpredictable. It refers to people having very short steps or a complete inability to move in any direction. Often this starts with someone might have a really hard time just taking those first few steps when they get up out of a chair, but once they get going, they're okay. Common places beyond that are when someone's going through a doorway, where they're going through a narrow passage, when they're trying to turn. So think tight bathroom spaces, kitchens, trying to pull open a refrigerator door and take a quick step back and getting stuck. And as time goes on, we may see freezing kind of even on straight, wide open pathways. Freezing of gait is associated with falls. It's associated with a really strong fear of falling, and it's associated with a poorer prognosis and decreased survival, probably because it's so associated with falls and injuries. And there are things that we can do, even though this is a very tricky symptom. So I've told you all about these symptoms. Where's the relief? Well, the great thing is there are a lot of things that we can do. Let's talk first about the general idea behind treatment. Okay, so this is a graph that I drew. This is not drawn to any scale. Okay, but here's this general idea. So the y-axis is dopamine. All right, this is sort of the chemical, the neurotransmitter that helps us with movement. And so if someone didn't have Parkinson's or didn't have Lewy body dementia, their level of dopamine would stay roughly 100% over time. There's a little bit of decline with aging, but not super significant. But in someone who has Parkinson's disease or has dementia with Lewy bodies, their dopamine levels start to decrease because the brain cells that are producing dopamine start to die off prematurely. And so the level of dopamine in the brain is decreasing slowly over time. What's really interesting is actually so many other cells and areas in the brain compensate for that loss of dopamine. So for a long time, many years, even though a person's dopamine level is dropping, they may not have any clear Parkinsonism symptoms. So what's sort of glass half empty, glass half full is that by the time symptoms are noticeable, people have lost a significant amount of their dopamine. They may have had some non-motor symptoms that have, when we look back in retrospect, we go, oh, wait a minute, you were constipated and you were acting out your dreams during sleep. Those could have been early signs. But at some point, people show up and they get diagnosed either with Parkinson's disease or dementia with Lewy body, or the timing is unclear. And we just say Lewy body dementia to capture everyone, right? And so what happens is, for some people, they may get diagnosed and their symptoms may be mild enough that they're not bothered by them. It's not impacting their daily life, in which case we don't need to start treatment for the motor symptoms. The time to start treatment is when the limitations are bothering someone or getting in their way. And so at some point, we reach that time, right? The dopamine is decreasing, and the person comes back and says, okay, this is really bothering me. And that's the time where we may start a medication. And the goal with that medication is, if this red line is that person's own dopamine that they're still making, let's say that that's 40%. We want to give them back enough medication to try to get them up to 100%. Unfortunately, there's no blood test, there's no brain test that tells us exactly how much you're missing that could guide us and say, well, this is the proper dose for you. I wish that we had algebra like that. Instead, we go with what we know. We start low, we go slow and increase our medications. We judge which medications to use based on what other medicines that person might be taking, what other medical problems they might have, how easy or difficult it is for them to get medicines, to take them multiple times a day. But the goal is, if you're making 40%, we want to give you something that adds up to about 60% so that you get to 100%. You're functioning as close to baseline as you can be. The challenge is, as time goes on, if we keep that amount that we're giving you the same, but you are making less and less dopamine over time, well, over here, you were making 40%, we added 60%, we got to 100. If down here, you're making 30% or 25% of your baseline dopamine, and we're still only giving you 60% on top of that 25, well, that adds up to 85%, not 100. And people feel that difference as, my symptoms are coming back. That must mean the medications aren't working. Unfortunately, that medicine is going to keep doing its job, but it works in combination with your own dopamine. So if your own dopamine is changing, either we need to make up for it, or we're going to see that gap. We're going to see that change. So there's this myth out there that the medication stops working. That is untrue. The medication is always going to work, but symptoms and side effects may cause us to change or peel back on medicines as time goes on. Okay, there are a lot of different things we can do to give someone back dopamine in their brain or enhance the dopamine they've got to make it work better, to try to help with these movement symptoms. So our oldie but goodie is carbidopa levodopa. So this comes in a lot of different formulations. Sometimes we refer to this as Cinemet. It hasn't been brand name for decades. We call it Cinemet because, as a movement disorder neurologist, I'd otherwise be saying carbidopa levodopa 1,000 times a day, and that's a tongue twister. But it was actually named Cinemet for a really cool reason, which is levodopa was discovered decades and decades ago. And scientists found out that levodopa, once it gets to the brain, is dopamine. It's what you're missing, which is amazing. But it's very hard to get levodopa to go to the brain and not be absorbed elsewhere in the body. And when it's absorbed elsewhere in the body, it causes a lot of nausea or emesis. Okay. And so very smart scientists figured out, wait a minute, what if there's a way to block it from being absorbed in other parts of the body and just kind of boost it all the way up to the brain, right? So if you imagine a space shuttle, we care about the rocket getting up into space, but it's got those booster engines on the side, right? They help it get where it needs to go, and then those boosters fall off. We don't know where they go, into the ocean, somewhere. I don't care. For the purpose of this analogy, carbidopa is the booster engine. It helps get levodopa to your brain and avoid vomiting and nausea, or without sin emesis, nausea and vomiting. So sin emesis without nausea and vomiting, Cinemet. So that's where that comes from. Okay. So typically the standard dose is 25 100 milligram pills. And people may take one, 1.5, all kinds of different fractions of that, but that's kind of our building block, right? Sometimes people will say, oh, I want low dose levodopa, because there is a 10 100 milligram tablet. The 100 milligrams in either of those is the levodopa. So it's not low dose levodopa. It's actually low dose carbidopa, which means you've got less booster to get the levodopa where it needs to go. You're more likely to have nausea and vomiting. The only time that a movement disorder neurologist or a cognitive neurologist might use that low dose is actually because of a really funny reason, which is that the 25-100s usually are yellow. There's a yellow dye in them. The 10-100s typically are not made with a yellow dye, they're made with a different color. And some people have an allergy to the yellow dye. A true allergy to levodopa is really, really rare. So if someone has allergy symptoms with 25-100, then their neurologist might think about 10-100. Otherwise, if you're on 10-100 and you don't know why, ask your neurologist. So there's also a controlled release tablet, which lasts a little bit longer, but maybe 6 hours most. And there used to be orally disintegrating versions of the Sinemet, of immediate release. These are great for people with trouble swallowing. Unfortunately, these are on national shortage and have been for almost a year, so these can be really hard to find. Finally, the other form of levodopa is an extended release capsule, and these last longer during the day, but people still have to take them multiple times a day, typically at least 3 or 4 times a day. They're pretty large capsules, and they can be harder to swallow for some people, and the dosing is a little bit wonky. So it can take some time to figure out the right dose, and because they are newer, they tend to be much more expensive. So what's the thought process? Because I'm going to tell you about a lot of other medications, and yet levodopa is still what we start with. Often it's what we come back to. So why? So imagine that you had a birthmark or you had a mole and you didn't want to see it. And the dermatologist says, this is benign, but it's going to keep growing slowly. You're not going to notice from day to day or week to week, but over the course of months and years, this is slowly going to expand. And you think, but I don't want to see it. And so you could go to your local drugstore, you could get the family pack of bandages, right? And you could pull out that little pinky sized bandage and you could slap that on top of the birthmark. And maybe for right now, it would cover it up. That would be enough, right? And it might be enough for months, it might be enough for years to cover up that birthmark. So a low dose or a less powerful medication for Parkinsonism might be fine in the beginning, might cover up the symptoms. But at some point, you're going to look down at that birthmark or that mole, and it's going to be peeking out underneath the edge of the Band-Aid. The Band-Aid hasn't stopped working. It didn't shrink, it didn't disappear. It's living up to its full pinky Band-Aid potential, right? But what was underneath has continued to slowly expand. So this is the case with Parkinsonism, is we can cover it up with a low dose of medicine for a while, but over time, it may outgrow that dose of medicine. Doesn't mean the medicine stopped working, just means we kind of need to shift our tactics. Maybe we slap on a second low dose medicine, another tiny pinky Band-Aid. Maybe we upgrade and we go to a medium-sized Band-Aid, right? You could go whole hog, put that blister one on top, right? We have all the options. So the other way to think about this is sort of the safe and wonderful or safe and powerful trade-off analogy. So if you had, oh, the slides are coming up kind of funny. If you had really bad knee arthritis, for example, right? You might go to your doctor and they could say, well, we've got sort of the big guns and the little guns, right? If you want just the safest possible thing, even if it's not as likely to relieve your pain, we could do something topical, right? Like an ointment or cream, icy hot, Aspercreme, one of those stinky kind of things, right? The side effect profile, pretty low, right? But is it really going to help if you've got really bad bone-on-bone arthritis? Probably not. In that case, a knee replacement is going to be our most powerful thing. It's most likely to give you big relief, but it comes with some sizable risks. On the other hand, let's think about diabetes. So if you've got diabetes, your sugar is high, your doctor might say, well, the best thing you can do to start is diet and exercise, right? Very low side effect profile. But if it's really significant or it's really out of control, on the other end of the spectrum is an insulin pump. Pretty intensive, but much more effective, right? So for most conditions, the safest thing is typically not the same as the most powerful thing. But in Parkinsonism, to this day, levodopa is both our safest and are most powerful, which is pretty unique, right? So that's why we talk about it first. That's why it's still kind of the bedrock. So there are other medications out there. MAOB inhibitors are one class of medicine. These can be things like rasagiline, selegiline, or sulfinamide. We can use these often as, we can sometimes use these as that first pinky Band-Aid, right? So a first layer of medication. These can be helpful to treat slowness, the bradykinesia. They may help a little bit with stiffness of muscles. Or they can be used in combination with some of the other medications. The challenge with these is they're not nearly as powerful as levodopa. So if someone is really bothered by their motor symptoms, they're not going to get a, whoa, this is amazing. So they provide mild symptom relief. There was a thought for a while that maybe these were slowing down progression of disease, but unfortunately that was proven wrong. So they help with symptoms, but they're not doing anything underneath. They do have some potential side effects, including nausea, headaches, dropping blood pressure. And what's most important is that selegiline, the older cousin in this family, interacts with a lot of different medications and interacts with aged cheeses and certain wines and can actually cause a very dangerous form of high blood pressure. This potential interaction is less common with rasagiline and sulfinamide, but pharmacists will still freak you out and ask you if you know about this. They can also interact with certain medications used to treat depression and anxiety. There's another group of medications called the COMT inhibitors or COMT inhibitors. This includes things like entacapone and opicapone. There was a middle one, but it was taken off the market. These can help if someone has those motor fluctuations, the ons and offs, but on its own doesn't do anything, okay? It's like a Band-Aid that's lost all of its stickiness. It's gonna fall off, it's not gonna do anything, right? It can only be there with levodopa. So these can be helpful. They're available, there are combination pills of the levodopa, carbidopa, and entacapone to kind of put it all together. They can cause similar side effects like nausea, headache, vomiting. They can cause some drops in blood pressure. In people who are prone to confusion or hallucinations, they can worsen those. And importantly, this one has a very unique side effect, which is that it can turn urine and feces bright orange and sometimes can cause severe diarrhea. The anticholinergics, we're not going to spend a lot of time on because these are an old class of medications that sometimes are used to treat tremor in younger individuals who are really tremor heavy. But these have a very well recognized risk of worsening memory and thinking in people who don't have any memory and thinking problems. And over time, they increase the risk of developing them. So in someone with Lewy body dementia, these should not be used. So they can cause all kinds of side effects, really overheating, dry mouth, dry eyes, vision changes, flushing, confusion, hallucinations, worsening of constipation, altogether just not a good setup. So we avoid them when possible. And this is just an illustration that even a small number of pills in this class of medication can add up to a slightly increased risk of dementia over time. So we try to avoid them. Next on the list is amantadine. So this is an old medication. It's been around for a while. It can be helpful in people who have those dyskinesias and motor fluctuations. Typically is used in younger folks. It comes in a couple of different forms, but it can cause a funky rash on the skin. It can cause swelling in the legs and feet, and it can significantly worsen confusion, hallucinations, and nightmares. So in folks with LBD, they may have been put on this earlier in the course of disease, but it may be something that gets weaned off sooner rather than later to try to avoid worsening symptoms. Then there are the dopamine agonists. So at a point in time where people thought mistakenly that levodopa might be harmful, they tried to come up with an alternative. And so these kind of trick the brain into thinking that they're dopamine. The challenge is, as we've used them, we've found a lot of other side effects. So they can do all the same things that levodopa can: nausea, vomiting, drops in blood pressure, increase the risk of dyskinesias. But specifically, this group of medications can cause impulse control disorders, meaning people who've never had problems with these issues before, or particularly folks who've had trouble with these issues before, having hypersexual behavior, overeating, gambling, compulsive shopping, spending hours and hours and hours on the computer. Um, they can be really, really dangerous and can kind of sneak up on people. And the risks get higher as the dose gets higher. People can also have sleep attacks where they just kind of nod off to sleep without warning or be really sleepy during the day. And that excessive daytime sleepiness is already common in LBD. So there are a lot of reasons why we might avoid dopamine agonists in folks with this condition. The ones in this group are pramipexole, ropinirole, and rotigotine. That one comes in a patch form, sometimes causes some skin itching. So we talked about the fluctuations. What do we do? If you or your loved one has fluctuations, one of the treatments that we might do is to increase the frequency of levodopa doses or to kind of smush them together to decrease the time between doses. We might add longer acting formulas or enhance the duration of each levodopa dose. Maybe we add on one of those booster kind of medications like a COMT inhibitor or an MAOB inhibitor. Or we may consider continuous dopamine with something like an intestinal gel pump. We're not really going to talk about that today. These are things that we kind of use more in folks with Parkinson's disease, less so in LBD. But we have to keep in mind that anytime we increase dopamine, that runs the risk of increasing hallucinations, confusion, and dropping blood pressure. What do we do for freezing of gait? So we might be able to get away with adjusting the levodopa a bit. Sometimes an MAOB inhibitor like rasagiline or selegiline or sulfonamide may be of benefit. And actually, one class of the medicines we use for the memory and thinking problems, so acetylcholinesterase inhibitors like donepezil or rivastigmine, there's some evidence that those may be helpful for freezing of gait. But the reason that the next three bullet points are in italics is because those are the most important things. The most important treatment, the most beneficial treatment for freezing of gait, those teeny tiny steps where someone gets stuck, is physical therapy. Bar none, that is our most effective. Next is treating anxiety. If that's present, that can be a big contributor to freezing of gait, and the freezing contributes to anxiety, and we get a vicious cycle. So if we can tease that cycle apart and treat them, that can help. We also want to consider if someone has orthostatic hypotension, which means a drop in blood pressure when they change position. That can worsen freezing of gait. If someone is having falls, we really want to think carefully about identifying the contributing factors. Are they wearing off? Are their meds kind of wearing off and they're falling at a certain time of day when they get stuck or they're really stiff? Are they having freezing of gait? Well, then physical therapy is going to be our best. Do they have trouble with balance? Are they impulsive? Are they getting up when they shouldn't? Maybe they're supposed to be using a walker, but care partner steps out of the room and boom, they're up, right? We need to treat that in a different way. And as I mentioned, orthostatic hypotension is this issue where blood pressure drops when someone changes position. So they might be fine when they're seated, they stand up, boom, blood pressure drops. People can have legs buckle, their legs may feel like they're giving way, they may look kind of dazed, or they may even pass out. So we really want to identify the setting in which people are falling. And I know that the other speakers in this series will probably tackle these head on. We want to think especially about tight spaces, bathrooms, kitchens. Where are people falling? What are they doing when they're falling? We don't want any multitasking, especially on the stairs. That's a setup for falls. And we want to look at home safety, evaluate if people have a lot of clutter or hoarding. That can be a big risk factor for falls. Physical therapy is going to be our bedrock for treating falls and trying to prevent falls. So we talked a little bit about this orthostatic hypotension. Sorry for that typo. So sometimes people were hypertensive. They had high blood pressure for many, many years. They're on medicine to lower their blood pressure. But now actually the Lewy body is causing their blood pressure to drop on its own. So maybe instead of adding something else on, we can actually just wean away some of the medicines that are lowering blood pressure and we can even out. We have to think really carefully that even though there are risks to blood pressure being high in the long term, there are also some very real risks of blood pressure dropping way too low, especially in the short term. So this can be a common and underreported cause of falls, fatigue, freezing of gait, and immobility. And most importantly, the symptoms matter more than the numbers. So someone might have blood pressure that normally hangs out at 100/60. That might sound really low to you, but that's their norm. But then they drop and they go to 70/50. That's a big problem for them, right? Where someone else, they might hang out at 140 over something, drop to 120/80, and that's a big drop for them, even though 120/80, technically normal. So the way that the person feels and how that changes as they change position, that's what really helps us define orthostatic hypotension. So this is just a very quick model. This came from a paper by Dr. Espay and Lang, a very famous movement disorders neurologist. And this tackles this old idea that we should save the good stuff, save the levodopa till someone really, really needs it. And in many, many ways, that has been proven wrong over and over again. And what this figure shows us is that that was called the treatment delay strategy way back when. Just tough it out, right? Till things get really bad. And if you look at these little tick marks on the bottom here, this is trying to model out a person's level of disability. And so if we say, nope, just tough it out, their disability gets real high for quite a long time. And then eventually we start levodopa. And this sort of lighter turquoise over here, this means the meds are working really well. And then when we start to get into this darker zone, this means all of a sudden we're getting those fluctuations. And this is maybe within a year of each other, right? We don't have a nice kind of honeymoon period. If you remember back to that first diagram where we've got that, squiggly line, and for a while people are in the Goldilocks zone, this is how long the Goldilocks zone lasts if we follow that plan. Alternatively, what then came into favor kind of in the 90s and 2000s was, well, let's try these dopamine agonists or something else. Let's save the levodopa for later, but we'll still give you something. And so people had some response, or disability crept up. They started a different medicine, held off the levodopa. Disability got better for a bit, but then gradually increases. We finally start the levodopa over here earlier than the old strategy. We get a little bit more of a Goldilocks period, but we still run into the fluctuations and the problems. But instead, if we say, don't mortgage some unknown future, let's give you the best we've got now to keep you functioning as well as possible now. We start levodopa, people have a good response. They have a full response for many, many years. Their disability levels go down and stay down for quite a while. And even though we make it out of the Goldilocks zone and we start to have some fluctuations and some dyskinesias, if we think about the cumulative amount of disability that that person has faced, our best strategy is treating the person with the best we've got as soon as they need it. So the better you function today, the better you'll function tomorrow. Very quick word on what I call the magic beans, or Mucuna pruriens. So this is a naturally growing bean. It has levodopa as part of its chemical structure. This is sold as supplements all over the place. It is unregulated. Okay, so there's no way to know that what it says is in the bottle is actually in the bottle, or what dose you're truly getting. It's very often used by patients and families. It's often not reported to their clinicians. But if you're taking it so that you get the active ingredient of levodopa, well, then you're at risk of getting the side effects of levodopa, whether it comes in a bean or it comes in a pill, same chemical structure. So nausea is very common, especially because this isn't coming with a booster rocket. It's not coming with carbidopa, so it's being absorbed throughout the body and causing more nausea. Most importantly, if you or your loved one are taking Mucuna as part of your routine, just let your doctor know so they can factor that in as they're calculating how much medication you might need or adjusting to side effects you might have. I'm going to skip over this for the sake of time, but just to say, as time goes on, if people are having side effects, if hallucinations or confusion are creeping up, there is a good way to slowly kind of peel away some of the medications. And the last thing that we would ever take away, if we take it away at all, is levodopa. Again, pointing to it's our safest, it's our best. So Lewy body dementia is a very slowly progressive disease. It changes over the course of weeks, months, years. So why do some people suddenly notice, oh my gosh, in the last couple of days, I've felt, my loved one has felt so much worse. Their walking suddenly has changed, or the meds are not working as well, or they're freezing or falling much more in the last day or two. Their cognitive status has changed. They're much more confused. They are having hallucinations that they never had before, or much worse than they were before. And we joke with our fellows, this always happens Friday at 4:30, right? Right as all the senior docs are leaving the office. So here's the thing to know. Lewy body dementia is a slowly progressive neurodegenerative disease. There's no point at which a whole group of dopamine neurons look at their watch on Friday at 4:30 and go, time to check out, we're out of here, okay? It doesn't happen. What does happen is that there's always a level of compensation going on in the brain. But if something else is going on, most often an infection somewhere else in the brain, that compensation kind of gets diverted elsewhere. And so if someone has a sudden change in their movement, in their confusion, in their thinking, think about urinary tract infection. Number one, number two, number three. Then pneumonia, other infections, COVID, flu, RSV, other infectious causes, so dental abscesses. If someone has diabetes, they're at a higher risk of having foot ulcers, pressure wounds on the bottom or the heels, severe constipation, dehydration or other metabolic changes, or new medications, medication errors, taking an over-the-counter cough or cold supplement that has diphenhydramine or DM. This is often in sort of the cough cold medicines that say severe plus max, or a Tylenol PM, an Advil PM. Okay to take the pain medicine, not okay to take the nighttime formulation. The PM additive medicine in there can cause a lot of confusion and sudden changes. So let your team know, but most likely your neurologist will say, go get your urine checked, go get a chest x-ray. Let's make sure you're not sick with something else. Is there anything else that changed? Okay, that's a lot. We've talked about symptoms that can arise. We've talked about ways that we can treat those symptoms. But who's going to help you manage those symptoms? You need to build a team, right? So your team can look something like this, or your team can look something like this, right? Assemble your Avengers. It takes a team. So who's on that team? The person with LBD should be front and center, okay? The care partners are next in line. They are critical. Family and friends play a huge role. And then your movement disorders or cognitive neurologist or maybe general neurologist can help manage these medications, often supported by a neurology nurse or a team of nurses, social worker, physical, occupational, speech therapists, and a host of other individuals on the team. So let's kind of take these one by one in terms of folks who can help with some of the movement symptoms. So physical therapist or PT, this is an allied health profession that uses movement, mechanical force, manual therapy, exercise, and other modalities to restore and improve mobility, improve and maintain function, and reduce pain. Our physical therapy colleagues can be great for helping to improve strength and walking, helping with transfers, getting up out of bed, out of a chair, in and out of the shower or the car, maintaining range of motion, and helping find and motivate people to do an exercise routine. But most importantly, not all physical therapists are trained in Parkinsonism or LBD. It really is worth your time and effort to find someone who gets this condition, that you don't have to do the explanations, because there are certain forms of physical therapy, certain exercises that have research showing that they make a big difference. But if your physical therapist doesn't know those exercises, you're kind of only getting half your money's worth. So LSVT, Lee Silverman Voice Treatment, global.com. And this is listed down here. So that's a place that you can go and literally click, I want to find a physical therapist, or I want to find an occupational or speech therapist. You can pop in your zip code and hit search, and it will find you a list of certified trained people who get it near you. It's worth the time. Occupational therapist or OT. This is another allied health profession that's great at assisting those recovering from or coping with physical or mental illness. And they assess and encourage rehabilitation focused on your activities of daily living. So sometimes occupational therapists are, really amazing with, there are troubleshooters. You go to them and say, I'm having a hard time with my handwriting, or I can't type, or I'm having a hard time with my phone, or eating, or drinking, or getting my arm into a sleeve, and they can help troubleshoot this with you. So they can improve performance of activities of daily living. They can help evaluate for driving safety. They can work with assistive technology, help with eating, typing, computer use. They can even evaluate for home safety and recommend modifications. They can be tremendous, tremendous members of the team. So we talked a little bit about speech and swallowing can be thought of as other motor symptoms. And so our speech and language therapists or speech and language pathologists are vital. They can help evaluate, treat, support, and care for people with difficulties with communication or with eating, drinking, or swallowing. So similar to the comment about LSVT for physical therapy or occupational therapy, LSVT or Lee Silverman voice treatment started as a voice treatment. So that same website, you can click speech therapy and find someone who gets it. And swallowing can change as LBD goes on. It's really important to get a swallow study. People can actually watch as you or your loved one swallows different consistencies of liquids and solids, see where things might be getting stuck, and recommend things that can help you swallow more safely. Try to prevent coughing something down the wrong pipe, developing a pneumonia. I often get asked by patients, by families, I think I'd do much better if I could just go for an inpatient acute rehab stay, just a tune-up, a couple of days, therapy all day long. Wouldn't that be great? Yes, that would be great. However, um, insurance doesn't support that except in certain cases. So the only real way to get to inpatient rehabilitation, often referred to as acute rehab, is someone has been in the hospital for an injury or a prolonged illness. They're evaluated by physical and occupational therapy, and the therapists say, yes, this person has the potential to improve, and they've got the stamina that they can handle boot camp, meaning therapy for at least 3 hours a day. And so if you meet those criteria and then you go to an acute rehab facility, you'll be doing a lot of therapy to try to, it's sort of really intensive, typically for days or sometimes weeks. Subacute rehab often is when someone's been in the hospital, they've been evaluated by physical and occupational therapy or speech therapy. Yes, they do better with some therapy, but maybe they're not quite up to the task of 3 hours a day. That's kind of the cutoff that PT, OT, and speech are looking at. And so this is often a space in a nursing facility or a nursing home that has kind of these short-term stay rooms or beds where people go, they get therapy, not quite as intense as acute rehab, sort of a little bit of a step down, but still better than maybe going straight home. On the flip side, outpatient rehab or outpatient physical, occupational, or speech therapy, you can do at a facility. You might go to a clinic, you might go to an outpatient side of a hospital. This requires a referral from your healthcare provider. That person will evaluate your function, come up with a plan for treatment, and work towards goals that you set together. Often this might look like a 1 hour session twice a week for 6 weeks, or a 1 hour session 4 times a week for a certain number of weeks. The problem is insurance limits the number of sessions that you can have and the number of times that you can have them back to back. So would it be great to just have continuous therapy throughout the course of this disease? Absolutely. Will insurance let you do that? No. So people will often need to take this break, typically 12 weeks, but continue practicing at home. And then as you get to the end of your 12 weeks, remind your provider, your physician, your neurologist, hey, I think I'm getting to the time where I could do physical or occupational therapy again. Can you write me a new prescription? In-home rehabilitation means like outpatient rehab, you need a referral from your doctor. It means that if someone meets criteria that they are homebound, the therapist can come to you. So if you're getting in-home therapy for one kind of thing, like if you're getting in-home physical therapy, that means that if you're getting occupational therapy, it also has to be in the home. You can't double dip or mix and match. So if something is outpatient, you got to go outpatient for everything. If something is in home, it's in home for everything. Wouldn't it just be better to have everything in home? That sounds so much more convenient, right? It sounds convenient, and there are wonderful home therapists out there, but they can be hard to find. Many outpatient, many home therapists have no training in Parkinsonism or LBD. They may be very rushed. The schedules can be really tricky. They may say that they're coming at one time, but then get delayed. Something happens. They show up 2 or 3 hours later, or they don't show up. They come when the person is really off, and that's not as helpful. It also means that they're only able to work with the equipment that you've got at home. Whereas at an outpatient physical therapy gym or occupational therapy gym, they have all kinds of equipment. They can mix and match, try different things, try different assistive devices, and see what works best for you. Okay, so we've covered a lot. In summary, LBD or Lewy Body Dementia is an umbrella term that includes both Parkinson's disease dementia, chicken and egg, and dementia with Lewy bodies, egg and chicken, under the same umbrella term. Parkinsonism itself refers to slowness, bradykinesia, stiffness, tremor if it's there, posture changes, balance changes, falls, and freezing. If someone has a sudden change, think infection first. So many of these symptoms are treatable. We have a lot of medications and a lot of non-medication therapies in our arsenal. Of the medications, levodopa is still both our safest and our most effective. Physical therapy and often occupational therapy are critical for these movement symptoms. And for the best benefit, you want someone who gets it, who's LBD trained, meaning they've gone through this LSVT certification. It takes a team. You can't do all of this on your own, whether you're the person living with Lewy body or a care partner or family member. Assemble your LBD Avengers, get answers, get active. Thank you so much for your attention. And I hope, I wish you the very best of health. Take care.
And we definitely wish Dr. Fleischer the best too. Thank you so much. If you guys, yeah, give some reactions there. I'm going to send her a heart myself. She's really going through a challenging time, and we so appreciate that she took the time to share this information with you all. All right, so now I'm going to go through some different questions that we've gotten ahead of time and then even today. And so one of those questions is, can you have Lewy body dementia and never get any movement symptoms? And actually, the question to that is yes. And so it is unusual. We find that most people get some sort of slowing or some sort of movement changes, but there are some people that can have very minimal Parkinsonism or changes to their movement. So that actually, yes, can happen. And that leads into another question, you guys, that we get a lot about the different stages of Lewy or progression of symptoms. And unfortunately, the same thing that causes some people to have these movement changes and some people not is the really unique and individual nature of this condition. And so when I was in clinical practice, we used to say if you've seen one person with Lewy body dementia, you've seen one person with Lewy body dementia. So just like the movement symptoms, the amount of different symptom families, cognitive changes, hallucinations, it's very unique to the individual. And so that has made it very difficult for researchers and clinicians to identify stages of progression of the condition. I know there are some out there that have put these are 7 stages. It's very important to note that those are not evidence-based. Those different documents have just been based on anecdotal information. When our researchers have actually really looked and tried to identify a progression or stages, they found it very, very challenging because of the heterogeneity or how individualized the presentation is. Okay, so I thought this was such a great question, you guys. What type of daily activity? And I'm an occupational therapist. If you guys don't remember, this was my jam was working with people with Lewy and Parkinson's in my career. And so this question really spoke to me. What type of daily activity in regard to keeping the brain active and keeping moving is best for someone with Lewy body dementia? Well, a couple things to that. Dr. Fleischer did mention the LSVT Global program, LSVT Big and LSVT Loud. Rose has popped some links in the chat for you to be able to access that Find a Clinician tool of somebody in your area. And we also did have the team from LSVT Global a few weeks ago here with us. And so she's popped in a link for you to watch that video as well if you have more questions. Also, if you missed it, I did do a webinar early in the year on purpose, and that is actually really important for me as an occupational therapist. When I really looked at what people needed to do, I first look at what they enjoy doing, and that's really unique. We all have different interests, but really, whatever you can get someone engaged in is beneficial. And a lot of times to do that, it might be going back to past interest, maybe different activities that they like to do previously. I have a friend right now who's an astrophysicist with Parkinson's disease dementia, and he still likes to read research articles and he likes to have different things about research, different videos he can watch. We find some that are more simplified now. So it's really kind of meeting that person where their interests are and getting them involved. And there'll be more on that, you guys, in upcoming webinars this year as well. So we have a question here. I see both DLB and LBD referred to. Are they basically the same? Well, I do think that Dr. Fleischer answered this early on very well, but I just wanted to stress that if we were doing an equation, Lewy body dementia, so LBD equals both Parkinson's disease dementia. Remember her chicken, so the movement comes first. The dementia came second. So that's your Parkinson's disease dementia and dementia with Lewy bodies. So when we're talking about Lewy body dementia, it actually includes both types. Dementia where the Parkinson symptoms came first, and then the dementia starts later on, and also that presentation where the dementia symptoms start first and the Parkinsonism starts at the same time or later on. I love this question. How can I best help my husband with Lewy body dementia to not pull in the opposite direction when I'm guiding him to the bed, the chair, or the wheelchair? And she says that she makes certain that he has unobstructed paths. Well, one thing I will say, and I worked on this a lot as a therapist, is typically we don't want to stand in front of someone and take their hands. I know that might feel really intuitive that that's what we should do is kind of pull them and lead them. Typically, that's not really the best. It pulls our body off of its center of gravity. The weight's too far forward, and then a lot of times that prevents someone from being able to move. I encourage you to have a physical therapist, just like Dr. Fleischer said, and an occupational therapist in your team to find what strategy works best for you and your husband. But typically, having some type of an environmental cue that could be taped lines on the floor. If you guys saw any of the vision presentations we did or the cognitive presentation I did last year, I've even had people get those little sticky feet where you can follow the feet standing beside of the person and walking with them often is better than standing in front and pulling. But just like the disease is very individual, the strategy that will work best for you and your loved one likely is too. So I encourage you to get a PT and an OT to see how you can address that in your own home. So, a question here about movement changes and the impact on digestion. And so, definitely, slowed gastroparesis or digestion of food is very common for people with Parkinson's and Lewy body dementia. Constipation is common, and also lack of movement. You know, if you've ever been hospitalized before and not able to get up and move around, a lot of times we do get more constipated. So having that movement can help our digestion and help. And then also the movement changes themselves do slow our gut down. But there's a lot more we're learning about this and kind of the relationship between the gut and the brain with Parkinson's. All right. So, should the caregiver insist on the person with LBD who has balance and energy problems utilizing a cane or walker when they refuse to utilize it outside the house? This is something I would once again really encourage you to get a PT and an OT in your team. Let us be the bad guy. But yes, if someone has a gait device, and just so you know, it's typically not a cane with Parkinson's disease or Lewy because of the amount of coordination that it takes to use a cane. So, what we see is a lot of times if somebody with Lewy has a cane, the cane just kind of gets waved around. It's not used appropriately. So typically, something like a walker with four wheels is more recommended, but that's something, once again, to try out with your physical therapist. And then once they have that appropriate gait device, they need to be using that no matter what the situation is. They need to use it in the home, outside of the home, wherever they can. And a lot of times I found that as therapists, we could help the patient understand, or the individual with Lewy understand that, like, hey, what is going to possibly really cause you disability or even a nursing home placement? A lot of times it's a fall and an injury. And so this is a way to prevent falls. And so that sometimes helps people to really think, okay, that ounce of prevention is worth a pound of cure. Sometimes we can't come back from those injuries after a fall if they're really significant. So we want to do as much as we can to stay safe. All right. So, is physical therapy as effective as medicine? And I think Dr. Fleischer really kind of addressed that exercise is truly medicine, and working on these movements, working on how to move with your therapist safely. And also, you guys remember that there's that sensory motor disconnect. Our people with Lewy body dementia don't, and Parkinson's, don't feel that their movements have gotten smaller. They don't feel they've gotten slower. They're not a lot of times really aware of that and how to change that. So that's where the role of therapy can help in practicing what those bigger, more normal movements feel like in regards to doing daily activities, walking around the home, getting in and out of chairs, and things like that. So, somebody asked here about sleep and how to and reverse sleeping patterns. We are going to have, you guys, a webinar upcoming really soon on sleep in Lewy body dementia. But just in relationship to movement, I wanted to touch on, a lot of times activity is very important for managing our sleep cycles. And so keeping some kind of a consistent daily routine, where I used to talk with my clients about peaks and valleys. So having times that there's activity, right? Maybe we're going out and walking around the neighborhood, or even just walking around the house, but getting up, moving, doing things like that. Then having some times that you're able to rest, even maybe take a nap, but having that consistency where you're active more during the day. So then the body is ready to sleep at night. And we'll get more of those sleep strategies and information about sleep in that upcoming webinar. So, I had a question here about types of exercise programs or physical activity that can help slow the progression of these movement symptoms. Definitely LSVT, big is one. Also, doing cardiovascular exercise, getting the heart rate up. That needs to be done in a way that is safe, and of course not going to induce a fall for people with Lewy. And that's why starting with a physical therapist is really best, so that they can identify, is it maybe using a stationary bike? Is it maybe doing some chair-based exercise? What is going to be most safe and also enjoyable for you and your loved one? All right, let me take a look really quick at the Q&A here before we wrap up and just see. The social worker on the team. You guys, the social worker can really help you find a lot of resources out there, and can help you find therapists in your area, and falls assessments, connect you with the local area on agency on aging to help do maybe a home safety evaluation. So lots of good. I special place in my heart for social workers. We also have a presentation coming up from an amazing social worker in a few months too. Excellent. So I think we've covered most of the questions here. I'll take a look after the event and see if I missed any, and you might get an email from us answering it. So, for that, you guys, I just want to wrap up here and thank you for all the questions. On behalf of the Lewy Body Dementia Association, I'd like to thank you for your time, your attention, and also your understanding with us today. And also, we'd like to thank Dr. Fleischer for sharing her presentation during this very challenging time for her family. Our collective thoughts and well wishes are with her. I'd like to take this opportunity again to mention the Lewy Learning Center, where you'll be able to access this course. And as I mentioned, it'll be divided into little smaller chunks. So instead of having to listen for the full hour, you could watch probably 10 or 15 minutes of Dr. Fleischer and come back to it later when you have more time. And then also, we'll have some physical and occupational therapists providing content on there about home modifications and strategies to help you live well with these movement changes. As a reminder, you're going to get an email in about a week with a link for the recording of the presentation. We invite you to check our events calendar frequently at the bottom of the homepage on our website for details and registration on upcoming events. And mark your calendars for our next webinar on Thursday, March 21st at 2 p.m. How to find and participate in clinical trials, practical advice, and real world examples. And we will continue to have these webinars roughly every 2 weeks over the course of the year. Please take a moment now to complete that survey that we'll launch after we end the webinar to inform our future content. And we hope to see you all again in the future. Thank you all and have a wonderful weekend. Take care.